And it's my request to everybody that if at the beginning, sometimes it happens that sometimes we forgot to start the recording, please remind us because me or Chinmada, anyone usually reminds it, but in case you forget. So what is trigeminal neuralgia? Trigeminal neuralgia is a facial pain which involves one or more division of the trigeminal nerve. So where lies our trigeminal nerve? Our trigeminal nerve starts from the pons and then it continues, and then at the level of the Meckel's cave it forms the trigeminal ganglion. Now, when there is a demyelination in one or more branches of the trigeminal nerve, which could be idiopathic or which could be secondary to different disorders, like it could be secondary to a aberrant vessel which is close to the trigeminal root entry zone or the trigeminal nerve, or sometimes it might happen it is because it is secondary to some lesion, for example a CP angle tumor, or because of the multiple sclerosis, then it is known as a secondary trigeminal neuralgia. But whatever the reason is, the basic pathophysiology in most of the cases is that it is the demyelination, either idiopathic and or sometimes presence of congenital aberrant vessels, that is also considered under idiopathic only. And in those conditions, we see this type of pain. Now, what is the nature and character? First of all, as it's a trigeminal neuralgia, it is supposed to be located in one or more divisions of the trigeminal nerve that we can easily understand. Then it is sudden, electric shock-like, lanceolating. These are the terms by which patients try to describe this type of pain. And it is triggered by chewing, speaking, touching the face, etc. And what happens when we put the patient in OT? Sometimes before the painting and draping, the patient starts frowning because even the butadiene gauge, when we are cleaning the skin, it becomes painful for the patient. Sometimes in very severe diseases, it happens the patient comes in the OT, in the clinic, and they ask to switch off the fan because the blow of the air that is coming, that becomes painful for the patient. So it is a very sensitive disease, and sometimes the patient becomes actually uh, hopeless because of this disease, and sometimes it has been seen in past that people have committed suicide. So another name of the disease is a suicidal disease. And surprising fact is, it is having no neurological involvement in most of the cases. Neurological examination will be normal unless and until it is secondary to some disorders like a CP angle tumor, where the features suggestive of that tumor or because of that tumor, whatever features we are getting in the cranial nerves, that we can get. It is triggered by chewing, speaking, touching face, etc. Already I have told. And pathophysiology, in most common cases, the idiopathic trigeminal neuralgia, there could be aberrant vessel, but it is not necessary. That's why I have put a question, because in a number of cases, we found no anomaly in the blood vessel, even in MRI. Though you should remember, in every case of trigeminal neuralgia, nowadays there is no excuse for not doing an MRI because it is such important. Now, if you look at the male-female ratio in the trigeminal neuralgia, it's more common in female, and usually against 3 female, 2 male patients are affected. That means the ratio is 1.5:1, or you can call it a 3:2 ratio. Peak incidence occurs at the 50s or 90s, and 5% patient is having the family history. Among the divisional distribution, you will find that most common distribution is V2 plus V3. That means involving the maxillary and mandibular division of the trigeminal nerve, and only V2 alone, and all three becomes the second most common. Third most common becomes the V3 alone, then V1 plus V2, and sole V1 is the most rare form of trigeminal neuralgia. So in most cases, we'll be targeting towards the V2 or V2 plus V3 cases. V1 is comparatively rare, and V1 is involved only in 20% of the cases. But remember, when V1 is involved, usually you have to be more careful because V1 is the nerve that is known as the ophthalmic division of the trigeminal nerve, and the ophthalmic division supplies the eye and the sclera cornea also. So what happens if you are doing a lesion at the V1 at a very high temperature, so it will result in an anesthesia. That means if you do the radiofrequency ablation at V1 at a very high temperature, it will result in actually the corneal anesthesia. And when the corneal anesthesia happens, the problem occurs is that in those cases, it will be very difficult to manage because it can lead to exposure keratitis, and in future you might go into the complication. So if at all V1 is to be lesioned, then what we have to do? We have to do the lesioning at a lower temperature, number one. Number two, ask the patient to use eye drops and spectacles, even it's a 0 power spectacles regularly, and at the night time, at least for the initial 2 months, ask the patient to use a eye ointment. So these are the things what you have to take care of while lesioning the V1. Or there is another way out, that in those cases you can go for a balloon compression. Now coming to the history, what you are going to ask in the history of trigeminal neuralgia and how to diagnose. Remember, trigeminal neuralgia, the initial diagnosis is based on the history only. And in clinical examination, you might find absolutely nothing. Sometimes in investigation, we might something, but in investigation, in idiopathic trigeminal neuralgia, it is absolutely normal. So what you are going to ask in the history? First of all, the pain nature. Remember, there are different type of headaches. Some headaches comes in attacks, some headaches remains constant or continuous, or sometimes just 1 second. So the question is, here the pain comes in attacks definitely. Most of the attacks are of small duration. Yes, neuralgic pain are of small duration, but sometimes it might happen instead of one attacks, there could be successive attacks one after one. So patient might be having for a quite some time there is pain at that area. And what the patient usually does, he tries to clench the teeth and just become standstill so that it can automatically go away. Then, whether the attacks are unilateral or not, definitely in trigeminal neuralgia, the attacks are unilateral. And where it occurs at the region of the trigeminal nerve. Now, the question you also be inquiring that whether there are unilateral autonomic symptoms or not. Though I have written it in the form of unilateral autonomic symptoms, but you have to tell, explaining the patient what is unilateral autonomic symptoms. So, what is the unilateral autonomic symptoms? Unilateral autonomic symptoms usually are considered that there could be redness of the eyes, there could be puffiness in one side of the face, there could be stiffness of the nose, there could be lacrimation in the eye, and these are usually found in a group of disorders which is known as the trigeminal autonomic cephalalgias, and one of the most common member of that it is the, we already know it is the cluster headache, and the other members like Shank syndrome, Suna syndrome, they could be present like in the unilateral autonomic symptoms, but in trigeminal neuralgia, usually there will be no unilateral autonomic symptoms. Now, after the history, we should move to the examination. And in examination, we have to do a thorough clinical examination for all cranial nerves, and the result will be normal in idiopathic trigeminal neuralgia. In secondary trigeminal neuralgia, features either suggestive of a angle tumor or suggestive of a multiple sclerosis could be found. Now coming to the differential diagnosis. So what are the diseases that can be confused with the trigeminal neuralgia? First, persistent idiopathic facial pain or the atypical facial pain. It is one of the differential diagnosis of trigeminal neuralgia, but there is a difference also. Here also there is unilateral facial pain, but the facial pain nature usually of dull aching, and it is also non-remitting, and sometimes here you have to use the gabapentin, which sometimes we use for the trigeminal neuralgia as well. Next comes the dental causes or dental disorders. Remember, this is a very common differential diagnosis for trigeminal neuralgia, and it is more commonly picked up on examination because the concept of trigeminal neuralgia is not there clear for all the physicians. In fact, most of the physicians, as per the MBBS knowledge, the trigeminal neuralgia, the concept is there definitely, but there is not detailed analysis. So even in my MBBS time, I can remember what I know about the trigeminal neuralgia is that it's a facial pain syndrome, and carbamazepine is the drug of choice for the trigeminal neuralgia because it comes in the MCQ. So everyone knows that the carbamazepine is the drug of choice. But how the disease appears, and they might not have seen a single patient of trigeminal neuralgia, that can happen. So what happens? These patients are initially diagnosed as a dental disorder. So ultimately the patient undergoes sometimes only clinical examination, sometimes multiple x-rays and nothing is found. And sometimes in most cases, sometimes it might happen that the dentists have taken off 2 3 tooths, and after that he realized that taking out the tooth is not relieving the patient. So it happens in, for my case also, in a number of times I have found trigeminal neuralgia patient coming or referred by a dental surgeon, and after extracting 2 3 tooths of that side. So it is not uncommon, it's quite common, and every pain physician have seen this situation. Next comes the temporomandibular joint disorder. So what is temporomandibular joint disorder? Temporomandibular joint disorder is mainly the arthritis or arthrosis or arthropathy of the temporomandibular joint, which remains just anterior to the tragus, and sometimes this pain from the temporomandibular joint can be mislinked or mimicking the trigeminal neuralgia pain. But there is again difference, especially at the early phase. TMJ disorder, as it's a joint pain, it is a primarily nociceptive pain, whereas the trigeminal neuralgia is primary and neuropathic pain. Though both the pains can be aggravated by opening the mouth, in temporomandibular joint disorder, sometimes by opening and closing the mouth, a click sensation can be felt over this point, but which is usually absent in the trigeminal neuralgia. And in temporomandibular joint disorder, initial part of management is conservative with the help of the tooth blockers, splint, and in those cases also we can go for a intra-articular injection, intra-articular TMJ injection for the TMJ disorders. But it is also considered a differential diagnosis for the trigeminal neuralgia, and it happens for my in one of my cases. What happens because of the trigeminal neuralgia? It was very painful. So what happened? I have completely done the radiofrequency ablation, and after the radiofrequency ablation, all the neuralgic pain is gone, but still the patient is having some problem in opening and closing the mouth. And at the time when I am actually in reality able to examine the patient, I have found the patient is having associated temporomandibular joint arthrosis as well. So in that case, after the radio frequency of the trigeminal neuralgia, we have given injection at the temporomandibular joint, and then the patient becomes normal. Now coming to the other diagnosis, cluster headache, I have already told about this. In cluster headache, there is usually an unilateral retroorbital severe pain, and it is always in moderate to severe level, and these pains are also short lasting. Usually it remains from minutes to hours. Okay, usually most commonly 2 to 3 hours, might it might stay 90 minutes to 180 minutes. So in cluster headache is also a differential diagnosis, but in cluster headache, usually the unilateral autonomic symptoms are present, and you have to differentiate from the cluster headache. Sankt Shuna, also a part of trigeminal autonomic cephalalgia. They are very short-lasting neuralgiform pain, and that also needs to be differentiated from the trigeminal neuralgia. Next comes the glossopharyngeal neuralgia, where from the glossopharyngeal nerve, the pain mostly remaining at this point and sometimes going at the base of the tongue, and sometimes it can come up to the ears. So we have to differentiate it with the help of a diagnostic block. But remember, glossopharyngeal neuralgia is comparatively rare than the trigeminal neuralgia, but it could come to your mind, but these could be the differential diagnosis, especially when you are diagnosing a mandibular division. If you have any confusion, you can go for a diagnostic block for the Gasserian ganglion, or specifically you can go for the mandibular division of the trigeminal nerve, and also for the glossopharyngeal nerve diagnostic block to make out that which type of neuralgia the patient is suffering from. Now coming to the clinical practice algorithm. Now, patients with intense paroxysmal facial pain are expected to subject to the MRI scan in all cases. That I always tell every of one of my students that in this regard you should not miss the MRI scan, because what happens, you might clinically diagnose but you cannot diagnose what is causing it. It could be a malignancy, it could be a small tumor that is compressing on it. So you have to do MRI in all cases before doing the radiofrequency ablation or any other interventional pain procedure, and then you have to go for the differential diagnosis and try to find out what is the cause. Now, first part of the treatment of the trigeminal neuralgia is definitely with the help of medications. Okay. So, what are the medications commonly used in trigeminal neuralgia? I will come later, but always remember, in every trigeminal neuralgia patient should have a proper pharmacological therapy. If the patient is not responding with the pharmacological therapy, or the patient is having non-tolerability, it could be in the form of allergy, because in carbamazepine we know sometimes there could be severe form of allergy. Even I have seen cases of SJS with the carbamazepine. So you have to be very careful. Though in India there is no genetic testing available for doing it, but you have to be very careful. And if the patient is responding with the treatment, continue with the conservative management as long as the patient is able to tolerate the medicine, and as long as it is not hampering the daily activity of the patient. If the patient is not responding, or in the case it is not tolerating the medicines because of any reason, then we can think of an interventional management. And the choice of interventional management in young patient is the microvascular decompression, and in elderly patient it is the radiofrequency ablation, or we have also the balloon compression and the neurolytic use. Now coming to the medications. So what are the medicines available for the management of the trigeminal neuralgia? The first drug is the carbamazepine. Usual starting dose nowadays, as the sustained release preparation is available, we commonly start with the 200 milligram sustained release preparation at bedtime, so that the side effects are minimal. And if the patient is able to tolerate the medicines, and then according to the patient's response, we usually increase the dose up to 800 milligram. If carbamazepine, the patient is not able to tolerate, or that it is causing excessive side effects, so we can shift to the oxcarbamazepine. Usual starting dose is 150 milligram, sustained release at bedtime, then gradually increase up to 900 milligram in most of the Indian patients. So these are the primary two medications with highest evidence in case of trigeminal neuralgia. Then comes baclofen. Baclofen is also used for the trigeminal neuralgia, though it is also a muscle relaxant, but it has been found to have a good effect in trigeminal neuralgia. Nowadays, instead of initial recommendation that 5 milligrams 3 times a day at initial part, we usually go for 20 milligrams sustained release preparation at bedtime with the baclofen, and then we increase gradually up to 80 milligram per day. If none of these are effective, then we can try gabapentin or pregabalin, or sometimes phenytoin can also be tried in the conservative management of trigeminal neuralgia. And these are the usual dosage of medicines. So lamotrigine, primidone, valproate, clonazepam, all have been tried with varying success rate. Okay. But most common drug you should always remember is carbamazepine and oxcarbamazepine. And in oxcarbazepine and carbamazepine, the fewer side effects include, the most important is definitely allergy. You have to be very careful. Other side effect that can occur is the sedation, for which sometimes you have to reduce the dose of the drug. Sometimes there could be GI side effects like the nausea, vomiting, non-tolerance with the carbamazepine, that also happens. In those cases also you can reduce the drug, but unless and until if it is a allergic reaction, you have to stop it. In elderly patients, when we are giving, sometimes it can cause hyponatremia, that you should know and you should be careful of. And also while going for the carbamazepine therapy, check for the CBC and also the thyroid profile, okay, because sometimes it can change that also. Now coming to the initial interventional treatment options. So what are the interventional treatment options? As I already told, microvascular decompression, surgical, where the abundant vessel is removed from that area and it is separated by a sponge or felt. That is done for the young patient because it has been shown to have a long-term effect better than the others. But as it is a full-fledged neurosurgery, so even some young patients sometimes refuse to undergo these procedures, and they ultimately we go do radio frequency for those patients also. Another alternative, which is non-invasive, nowadays coming a little, but though the duration and pay of pain relief is comparatively smaller than the radiofrequency ablation, is the stereotactic radiation therapy or gamma knife therapy, where the gamma rays are concentrated at the level of the Gasserian ganglion, and that can give a pain relief. The usual pain relief period is something between the 6 months to 1 year. Though there are some studies which are claiming that their pain relief period is almost similar with the radiofrequency ablation, but in reality, a number of gamma knife failure patients we have treated with the radiofrequency ablation after that. Okay. Next, coming to the percutaneous balloon microcompression. This is a comparatively, I should not say it's a newer technique. This technique is also there for long, but especially it is effective when V1 is involved, because what happens in balloon compression, the motor component is affected more, but the sensory component is affected less. So what happens if the most involvement is the ophthalmic division, then we can choose it over the radiofrequency ablation. but, here- but again, for most of the patient, it doesn't become very much economical because the cost of the Fogarty's catheter and the balloon is comparatively higher compared to the radiofrequency machine and the needle. So here also some patients prefer doing the radiofrequency, and we also do the radiofrequency at a comparatively low temperature. Then comes the percutaneous glycerol rhizolysis. This is one of the techniques that has been there for very long, and even in my early career I have done the percutaneous glycerol rhizolysis in trigeminal neuralgia, because that time I do not have the radio frequency with me. So what is done here, it is a very simple thing. Their main technique was like retrogasserian injection of glycerol, which is a complex and cumbersome technique, and nowadays most of the pain physicians do not prefer that. So initial nowadays, previously how we done, we have just given in the same way as alcohol is given at the Gasserian ganglion, we inject the glycerol. But I will say you the what was the classic technique from which the retrogasserian injection of the glycerol name came actually. Next, definitely the percutaneous radio frequency. That is a big advantage of the percutaneous radio frequency, is that it can selectively block the fibers. For example, if you want to block the mandibular division, you can come a little lateral towards the foramen and come a little outside. Then you will be selectively able to block the branches from the mandibular division. So it gives an advantage that if it is a mandibular, maxillary or ophthalmic, you can selectively block those fibers, and you can do at a different temperature. So that is the one of the biggest advantage of the radiofrequency ablation, that instead of a whole anesthesia, you will be having anesthesia of a specific part or specific fibers. So in that way, it is more beneficial, especially when the mandibular division is involved. You can go for the radiofrequency ablation, and here what happens, you can selectively block the fibers of the mandibular division. Don't go too much inside or towards the fibers of the foramen rotundum or towards the superior orbital fissure. You remain close to the foramen oval so that you can selectively block the fibers of the mandibular division. Next comes to the Gasserian ganglion stimulation. This is one of the experimental technique, but it is not used regularly nowadays. Now coming to the anatomy. From this part, the subject today's is becomes again a little bit difficult, because now we will be discussing a little more about the anatomy. So where lies the Gasserian ganglion? Gasserian ganglion remains at the middle cranial fossa. So let me do one thing. Let me take a model of brain, sorry, skull, so that I can show you. Are you able to see this? Okay, I think everyone, let us open this skull. Okay, so can you see the skull? Okay, let me do one thing. Let me switch off the sharing so that you can see it in a large way. Now can you see it?
Yes.
Okay, fine.
Yes,
Spotlight for
sir.
everyone. Now, in the cranium, if we look at clearly, there are three steps. This is the first one. This is known as the anterior cranial fossa. This is the second one, which is known as the middle cranial fossa. And this is the third one, that is the known as the posterior cranial fossa. Now there is a bone which is going from one side, in both the sides it is there. This bone is known as the petrous part of the temporal bone. As you can see, it's a part of the temporal bone. So it is the petrous temporally or petrous part of the temporal bone. If you look from the midline from top to bottom, here you can see one small projection. It is known as the crista galli and it's a part of the ethmoid bone. Then you can see small foramens here. Okay, these are known as the cribriform plates through which branches of olfactory nerve goes. And as we come posterior, this portion we are coming to the lesser wing of the sphenoid. Those who can remember the sphenoid bone, you can easily understand this portion is the lesser wing of the sphenoid. And here we get small processes. These are known as the clinoid processes. When what we are touching is the anterior clinoid process. These are the middle clinoid process and these are the posterior clinoid processes. And so 1, 2, 3. But that much of anatomy is not required. Just know the basic that this portion there is a groove that everyone can see. This is known as the Turkish saddle back shape, or this is known as the area for the pituitary. And what can anyone remember the name of the housing area of pituitary?
C'est la torsika.
Teletarsica, perfect. So that is the area. So here remains the pituitary. If you look at just by the side, and after that, after celetarsica, this portion is the posterior clinoid, and this portion is the clevus. And clevus actually leads to the foramen magnum. If you look at the medial cranial fossa, there are some foramens. So what are those foramens? From front, we can see a triangular type of foramen. I think everyone can see the foramen through which a portion of my hair is seen, black. Okay, so this foramen is known as the superior orbital fissure, and through which the first division, that is the ophthalmic division of the trigeminal nerve, comes to the orbit. So I think you can see this triangular foramen clearly. And just below the triangular foramen, can you see a small rounded foramen? Just below the triangular foramen. So it's a very small foramen. I don't know how can I show you more clearly. Okay, with this it is maybe possible. Okay, so if you look at carefully, there is another foramen just at the tip. Try to see just where my tip is going. At that tip, there is another foramen. This foramen is known as the foramen rotundum, through which the second division of the trigeminal nerve goes. And last but not the least is the main foramen. This is the foramen oval. So you can see here there is the oval foramen. Okay, how can I show that? You need something small. Okay, fine. I got a shiny, small, pointed pen, so it will be helpful. So if you look at, can you see now? There is another foramen.
Yes.
So this is the foramen oval. So now try to fit the ganglion within it. Okay. So here lies the ganglion. Here at this point lies the ganglion. From the ganglion, the mandibular division goes through this foramen. The maxillary division goes through this foramen, okay, and the ophthalmic division goes through this foramen, okay. 1, 2, and 3. Okay, and after this we have another small foramen. This is known as the foramen spinosum, through which the recurrent meningeal branch of the mandibular division, it comes back again to the meninges. So hope you have understood what are the structures. Now, what are the structures will remain medial to the ganglion? Medial means towards this side. So through this side goes the cavernous sinus and the ophthalmic nerves. Okay, so optic nerves. So optic chiasma will be just above, and through this cavernous sinus will be going the third, fourth, sixth cranial nerves. So these structures will be remain medial to the ganglion. If you look at the lateral side, what will be there? In lateral side, it is the temporal lobe of the brain. If you look at the posterior side, what structure will be there? It will be the midbrain with the pons, and then it will be continued at the medulla oblongata. Okay, so these are the structures which forms the relation with the ganglia. So we understood it is related to very important structures in all around. So in case if you accidentally touch, or if you do lesioning, more importantly if you do the hit lesioning in those structures, that could be very detrimental. So you have to be careful in selectively burning the fibers of the trigeminal nerve. So let's go back to the slide. This part everyone have understood, because this is a very important part. If you do not understand by looking at the slide and by reading, it will not be possible. So, what's written in the slide? It is located within the cranium in the Meckel's cleft, close to the apex of the petrous part of the temporal bone. Medially lies the cavernous sinus, internal carotid artery, and trochlear and optic nerves. Superiorly lies the temporal lobe. Posteriorly lies the brainstem. Anteriorly, it divides into its three branches, namely the ophthalmic, maxillary, and mandibular division. So if you look at in a cadaveric dissection, it will be looking like this. So through the foramen oval, the first part will go, through the foramen rotunda, the maxillary division will go, and through the superior orbital fissure, the ophthalmic division will go. So remember, when we are coming from the foramen oval, if you are most lateral and most less deep, okay, while we are putting needle from below through the foramen oval, we are moving up. So when we will be lateral and most superficial, then we will be selectively blocking the fibers of the mandibular division. When we are at the middle and slightly more deeper, then we will be blocking the fibers of the maxillary division. And when we will be the medial most and slightly up, that is deep most, then we will be lesioning the fibers of the ophthalmic division. And when we will cross it and we will hit the midbrain, then our patient will die. So you have to be very careful, because it all depends on the depth and location, and you have to be very careful while doing the procedure. Okay. So this part I have already shown. So this is a picture taken. So here you can see the foramen oval. This is the foramen rotundum. This is superior orbital fissure. This is the optic foramen. This here lies the foramen spinosum. This is the jugular foramen. So we have understood this area quite well now. So this everything is demarcated at this point. Okay. So now coming to the radiology. So we understood the structures from the midline, from anterior to posterior. Here we can see the same. So from anterior side it's the ethmoid bone, then it is continuing to the anterior clinoid, and then it is the sella turcica, and this is posterior clinoid, this is the clavus. And what is this shadow? This shadow is the petrous shadow. Remember, this petrous part of the temporal bone, they are not at the midline. But when we are looking from the lateral side under fluoroscopy, then the images of the left and right side, they usually coincide together and they form a single petrous shadow like this. And if you look at carefully, this petrous shadow will be looking like this. So if you look at here, this is the shadow of the petrous part of the temporal bone that we can see. And if you look at, this is the shadow of the clavus going to the foramen magnum. Remember this junction, okay, what I am drawing a small star, okay, this junction is very important. Why? Because while doing the procedure, our needle should be targeted to the clavopectoral junction, but it should not cross even for the ophthalmic more than 2 millimeter from this clavopectoral junction. Or ideally, to be in safer side, your needle should not cross the clavopectoral junction, because clavopectoral junction is not there in skull. It is not there, but it indicates the maximum width of the, here lies the clavopectoral junction, okay, so indicates the maximum width of the Gasserian ganglion, after which if your needle is going up, then there is a possibility you are actually hitting either the midbrain or you are hitting the temporal lobe if you are lateral. So this junction is very very important for point of view of us, okay, while doing the procedure. Now the rough estimation or location of the foramen oval is considered that from the anterior side it should be in a plane along the ipsilateral pupil. So if you draw a line which is actually creating a plane, and in that case it should be going along the ipsilateral pupil. Okay, and from the lateral side if you look at, it should be 2 to 3 2 centimeter just anterior to the clavus. Here you can see the foramen from below. So here also in this model you can see the foramen from below, because below is the only way through which we can reach. So from where we can target the foramen among so many areas. So foramen we can easily understand, this one is the foramen. Okay, so this one is the foramen. But how we can go? Remember, from this area it is not possible because they will need to be puncturing the tongue and all structures. So from where we can go? We can go in between the maxilla and mandible. So let us target in which area we have to go, like this. Now I think in between the maxilla and mandible you are able to see the foramen. So in the same vision we have to reach the foramen. So we have to be very very careful. Now this is the vision. Can everyone see the foramen oval in between the maxilla and mandible in the submental view?
Yes, yes.
Okay, so for yourself I am just putting a probe here. Okay, so you can see from where our needle should go. Our needle should come opposite side like this. Our needle should be coming to the foramen oval like this. Okay, but it is not being seen if I am holding. Okay, anyway, that we'll see in the next images and next pictures. Okay, so this will be our direction of the needle and we should go like this. Now coming to the indications for the Gasserian ganglion block. First of all, it is the trigeminal neuralgia. Then it is the secondary neuralgia. That is also trigeminal neuralgia. And in those cases where the conservative therapy fails, and also we do the radiofrequency ablation of the Gasserian ganglion while we are having a malignancy in the territory of the trigeminal nerve. That also helps to remove the pain, malignant pain as well. Contraindications includes the local infection, sepsis, coagulopathy, increased intracranial pressure, and the major psychopathology, because we need a patient's cooperation while doing the radiofrequency ablation. So we cannot do it in a completely anesthetized patient. Now coming to the equipments required for the block only. So where we are not able to understand whether this is trigeminal ganglion will help or not. So in that case, you simply take a Twinkie needle and you can go 22 gauge Twinkie needle, you can go to the ganglion. But in most cases what we do is the radiofrequency ablation, and for which we will require an 10 centimeter length and 2 to 5 millimeter active tip radiofrequency ablation needle. Okay, and usually we use a needle through needle technique to avoid infection. So for that you might take an angio catheter, and through the needle through needle technique you can go to the ganglion so that the skin common shells are not going inside. For the balloon compression, most of the requirements are the same except we need a 14 gauge 10 centimeter needle and 4 French Fogarty's catheter. So that is the additional requirement for the balloon compression. And the drug for the diagnostic block, most commonly used drug is the lignocaine 1% that we use for the infiltration, and inside we can give either lignocaine or bupivacaine. In balloon compression, usually in lignocaine and ivexol for the inflation of the balloon. For neurolytic block, nowadays alcohol phenol is having the negative recommendation, so we do not recommend it. So what we commonly use is the glycerol. Usually 1 ml is good enough, and usually 40 to 50% glycerol is used. Now, technique. The patient will be supine and we will be seeing under submental view, under the maxilla and mandible, we have to find the foramen oval. And after locating the foramen oval, we will be putting the needle in a approach which is known as the tunnel view approach. Now, if you have to burn the fibers of the ophthalmic division, you go like me, like this, most medially, and go the maximum depth. In the lateral view, you should check the depth. It should not cross the cleavopectoral junction, or maximum it just seen at the cleavopectoral junction for the ophthalmic division. For other divisions, it should be under the cranial bones only. You will not be able to see the needle tip, but at that point you have to do a stimulation. What type of stimulation? In radio frequency ablation. Please, those who have not seen the radio frequency class, that is already the recorded lecture we have given initially. So please look at that lecture, because radio frequency is very important for this procedure. In most of the cases, we do the radio frequency. So here what we do the lesioning at first lesioning most commonly done at 65 degrees Celsius, then 70, then 72, maximum we reach up to the 75 degrees Celsius. And in between lesioning, we check the corneal reflex. We also check for the patient's response during that movement. Okay, always check all the monitoring, including the heart rate, blood pressure during the procedure. And once completed, we usually inject small amount, okay, usually 1 milligram of a soluble steroid, most commonly dexamethasone, and then we take the needle out. So that's the usual technique for this procedure. And the direction, always remember, it should be towards the cleavopectoral junction but not crossing the cleavopectoral junction. So this is the direction of it. Okay, and how neurolytic can be used? For the neurolytic, usually we inject a very small amount of dye first, and we check whether it is intravascular or not, or it is going to the thecal cistern. Usually there is a cistern, so brain cistern is there, that is known as the trigeminal cistern. So whether it is going in the trigeminal cistern or not, in classic approach of the glycerol injection, usually patient is make used to sit, and then we usually put a little. I have not done it, remember, it is a classic technique, Gasserian glycerol injection. What I have done is a modified technique. There what is done, usually small amount dye is given, and then glycerol is given, then aspirated, but after sitting the patient. But that procedure is cumbersome and we do not do. And most of the cases what we do is nowadays is the radio frequency ablation. So put the needle, and after putting the needle, you just go for the stimulation. And once you check what will happen in stimulation, in the mandibular division, as we are having some motor component in the mandibular division, we all know mandibular division have an anterior branch and a posterior branch. In anterior branch, most of the branches are motor. They are supplying the muscles of mastication, namely the masseter, temporalis, okay, lateral pterygoid, and from the main trunk, it is getting a supply to the medial pterygoid as well. And also from the posterior division, there is a branch that is going to the anterior belly of digastric and mylohyoid. So what will happen? When you are stimulating, especially for the mandibular division, all those muscles supplied by the trigeminal nerve will be stimulated. Okay, but it is not abnormal, it is normal. And while after the lesion, sometimes there could be paralysis of the muscles, but as we have the bilateral muscles and bilateral supply, that is why usually it is not a problem for eating for most of the patients even after the procedure. So these are the usual technique for the neurolytic. Usually I have used the glycerol as well. So in glycerol, what you used to do in small portions, like you just give 0.1 cc, 1 cc up to zero point 0.5 to 1 cc maximum you give, and you take the needle out. That was the neurolytic injection to the Gasserian ganglion. And the most important is definitely the RF, that usually done in the following temperatures. And after doing the RF, you just take the needle out. But before RF, check for the sensory testing. Sensory testing is done at 50 Hertz and 0.5 volt. Usually, you might not in most cases go up to 0.5 volt. Usually, something between zero point 0.2 and zero point 0.3 stimulation starts coming, and the patient complains that at the area of my pain, I am getting paresthesia. And sometimes this time is becomes very painful. So you might use a little bit of local anesthetic or a little bit of sedative while you are very close to this ganglion. And after you have confirmed the needle position, then only you should inject sedative if required. And In most of the cases, I do under local anesthesia, and when I think the patient is aged, patient having cardiac problem, there are some issues might happen in OT. So what I do, I call an anesthesiologist. Okay, you don't take both the responsibilities. Okay. Nowadays, in most of the cases of trigeminal neuralgia, unless and until I am very confident that the patient will be easily can be done under local anesthesia, I do it myself. Otherwise, in most of the cases, I call an anesthesiologist to look after the patient during this procedure. Okay, so do the RF lesioning, and after the RF lesioning, you have to take it out. Balloon compression, similar technique. All the techniques initial part is similar. Only here sometimes we need a more sedation because it is a thicker needle and thicker catheter. And after putting it, you should inflate the balloon and keep it there for 60 seconds or more. Usually 2 to 3 minutes it is kept there and it is taken. And during balloon compression, check for the fighters as well. Now coming to the complications. What complication may occur? First of all, loss of corneal reflex. It is highest with radio frequency, approximately in 7% of cases. Be very, very cautious and careful while doing the ophthalmic division. Always ask the patient to cover the eye, and also after the procedure, give regular eye tear drops, tears plus, and also do another thing, that is the eye ointment at night. And in balloon glycerol, it is comparatively less. In balloon compression, it is minimal. That is why it is said that for the ophthalmic division, balloon compression is better. Motor deficit with the radio frequency, it is not that problematic, but it is highest with the balloon compression, moderate with the radio frequency, and minimal with the glycerol injection. But motor deficit doesn't becomes too much problem as we have a bilateral nerves and muscles also. Okay. Carotid artery puncture accidentally can happen. You have to be very, very careful not to do that. And always check the coagulation profile. Make sure the patient is not having any coagulatory abnormality before it to avoid it. Hematoma in the cheek might happen commonly, but for that you do a little bit ice compression and that is good enough. Accidentally, if you are not taken all sterile precautions, you might land up in meningitis. I should not recommend using a routine antibiotic in all cases, but definitely sometimes we use prophylactic antibiotic, though it can cause antibiotic resistance. Then coming to the comparison between these three procedures, radiofrequency lesioning, high pain relief rate, low relapse rate, high degree of effectiveness, high sensory deficit. Glycerol, slight sensory deficit, shorter duration of pain relief. Usually remember, in glycerol, the pain relief what we can usually obtain is around 6 months, 3 to 6 months, and it is not very high. So you have to do it again and again. So relapse rate is comparatively higher. Whereas the Gasserian ganglion compression, it is having slight sensory deficit, moderate rate of recurrence, and high motor deficit. So comparing everything, we usually prefer doing the radiofrequency ablation in most of the cases. This is a very old case which is being done myself and Dr. Chinmay both together long back in a hospital in Kolkata. Nowadays we have our own setups. We usually do not take the patient to any hospital, but previously we used to take that patient to different hospitals for this procedure. Okay, so this is the radio frequency machine, this is the radio frequency needle, and we are checking the lateral view while doing the procedure because we should not cross the junction. I think this photo is taken in somewhere in 2012 or 13. It's long back. Okay, so any questions?
Sir, do we inject local skin infiltration prior to putting
Definitely.
this?
In all cases, if when you are going, initially you inject a little bit local anesthetic before. Okay, 1% lignocaine, commonly we do before
Sir,
putting the.
and do we keep patients NPO for any pain procedures?
See, NPO is not essential, but the problem is in trigeminal neuralgia, at least for sometimes we ask because sometimes in some patients, if local anesthetic accidentally gone to the trigeminal system, there could be a tendency of vomiting that we sometimes found. So it is always better to have. But if you are not planning for sedation, it is not essential. If you are planning for sedation, then it is compulsory.
Also, sir, do you secure a cannula for all these pain
In all
procedures?
patients, okay, in almost all patients. Okay, cannula is a compulsory thing. And in trigeminal neuralgia, though Chinmada will differ and he doesn't give it, but I always give just after half an hour. I before half an hour I always give an antibiotic as well with that cannula.
So
How
we do
much how much local anesthetic you inject prior to a RF lesion? You
It
said
is a very small amount. Usually 0.5 ml is maximal. Okay. You have to be very careful because we have many times we have actually, because of the local anesthetic, we have to keep the patient hospitalized. So nowadays when we go, we give usually compared with high concentration, that is a 1 to 1.5% of lignocaine, but in a very small volume, 0.5 cc is the maximum.
Sir,
okay.
how about blocking these nerves once they are outside of the canal, sir? Is it possible to do it peripheral?
Yes, peripheral. That is a technique that also we do sometimes. For example, here, if this area is involved only, then you can avoid going to the ophthalmic branch. You can go at the supraorbital branch. Okay, and here there
Okay.
is a branch also. In the ultrasound guided course, actually yesterday we described this. Here we are having the infraorbital nerve, which is a continuation from the maxillary division. And when
No.
only this portion of involved, or there is a scar neuralgia, or the patient having postherpetic neuralgia, or a limited area trigeminal neuralgia, we can block only the peripheral part only. Okay, here we have the mental division, and also we can block specially for not for the ophthalmic division. There is no way, but for the maxillary division, there is another way technique that we will be discussing tomorrow in the next class. That in that case, from the lateral side, we can actually reach the after the foramen rotundum. The maxillary division comes in a fossa which is known as the pterygopalatine fossa,
Very fast.
and within the pterygopalatine fossa, we can block the maxillary nerve as well. Okay, and similarly, just posterior to the lateral pterygoid plate, we can block the mandibular division of as well. But the result is best with the Gasserian ganglion block. Okay, we have done
Okay.
all the blocks, but the best result comes with the proper Gasserian ganglion block. The maximum duration of pain relief comes.
Okay. Thank you, sir.
So about the cycles of the RF, always you do 3 cycles, starting with 65 degree, then increasing it to 70
Okay,
degrees, or how can we decide
okay,
how?
okay. So I am giving you the advantage of disadvantage of multiple lesions. So what is the advantage? If you are doing a lesion at a lower temperature just after giving the local anesthetic, usually what happens, if you do a lesion at 60 or 65 degrees Celsius, then the advantage is it is not that painful for the patient, and local anesthetics take time for the action. It is not that it takes 2 to 3 minutes, so you can wait that time as well. But the first lesion we want to do at a lower temperature because that gives a balance. Because once the first lesion is done, the second lesion is usually less painful for the patient, and we rotate the needle tip slightly so that we can increase the lesion area by rotating the needle. Because in most cases we take a curved tip RF needle and we rotate the needle slightly so that my needle is moving a little away from the previous lesion site so that the lesion will be bigger. And going the lesion in the graded way, the advantage is that if you do the first lesion at 75 degrees Celsius, usually it is very painful, because once the lesion is formed, then when we are increasing it, the pain usually reduces, so it is easy to do the procedure for the patient.
Okay, and for how long each cycle? 90 seconds?
Yes, remember all radio frequency. You please look at the radio frequency video. There is no point going over 90 seconds in conventional radio frequency, because at 60 seconds, usually the equilibrium achieved. So, what is equilibrium? Remember, if this is a radio frequency needle and around it the lesion is generating in the tissue, remember, the needle is not heated, it is because of the charges moving, the tissue around the needle is heated and the tip just senses the pain. So, what happens at 60 degrees Celsius, at 6, when we are keeping the temperature at fixed, for example, we are keeping at 75, and after 60 seconds, what happened? It forms an equilibrium with the surrounding tissue. The needle is at the at temperature of 75 degrees Celsius. Just away from the needle, it is 75. If we go little away, it is 70. Then gradually it is increasing within 2 to 4 millimeter. It goes to up to 37 degree. So once this equilibrium is formed, then the lesion size, even if you make it for 1 hour, it will not increase, because our tip will remain the same and the heat will be dispersed from the tip. So all lesion conventional, not more than 90 seconds.
Okay, for the Gasserian ganglia, we can only do V2 and V3 and not doing V1.
I have already told the V1 we can do, but while doing the V1, we should keep our temperature low, usually up to 70 degrees Celsius. Do not go beyond 70. Because what happens if you increase the temperature, pain relief period increases, the anesthesia which happens following the radiofrequency ablation. Okay, there will be definitely hyposthesia or anesthesia at the area of the radiofrequency ablation. The duration of that hyposthesia also increases. So while doing V1, you do at a low temperature.
Trigeminal neuralgia, sir. How
Yes.
common, how common you encounter V1 division involved in trigeminal
I have
neuralgia?
already told the V1 involvement is only 20% of the cases. It is rarest.
Sir, is there no diagnostic block for this, like we are doing for trigeminal?
See, if you are confused that whether my diagnosis is correct or not, okay, in that case you can go for a diagnostic block. But what is happening to do the diagnostic block, we require almost same equipments except for the needle and the radio frequency generator. So in most cases, if we are suspecting, usually we are very sure that it's a trigeminal neuralgia, we have done the MRI. So in a number of cases, we skip the diagnostic block and directly go for local anesthetic initially, and then we go for the radiofrequency ablation. But if you say that, if you are confused that whether it is a glossopharyngeal neuralgia or it's a trigeminal neuralgia, it is close to the mandibular division, I'm not able to make sure. In that case, you can go for a diagnostic block, and after doing diagnostic block, you can go for a radiofrequency ablation at a separate setup. But the problem is it increases the cost for the patient because you have to take the patient twice in the OT. All setups will be required twice.
Sir,
So,
also intralaminar cervical, sir, we said 10 ml we have to inject cervical epidural. It won't
Usually
cause
we inject 10 ml
hypotension.
because that usually covers up to the C3, C4.
Won't it cause hypotension, sir, when we have elderly patients and
See,
because
we what we do, we reduce the concentration of local anesthetic. Okay. In most cases, we do not give the local anesthetic beyond 0.5%. Okay, lignocaine. That is why hypotension do not occur there. If you give too much of local anesthetic, hypotension might occur.
yes,
sir, for
Okay.
RF lesion, if we do it at three different temperatures, do we change the probe slightly, sir, the position
Yes,
of the
we
probe?
rotate the probe slightly. We rotate the probe. If two divisions are involved, for example, first we are doing the V3 and then we are thinking the V2 is onto alpha involved. And also we ask the patient that when stimulating, we also ask the patient whether at the area of your pain you are getting paresthesia or not. So initially I have done the paresthesia, I got found the paresthesia at V2, I have lesioned the V2 division. Okay. And then we go slightly medial and slightly up, and then we again stimulate and then ask the patient. Though it becomes a little bit difficult because in the first go you have given a little bit local anesthetic. So
Yes.
this time the paresthesia will not be exact, but we try to elicit that as well.
Okay, sir. Thank you.
sir, in glossopharyngeal neuralgia, we are not giving dye, no, sir, for checking.
See, in glossopharyngeal neuralgia, if you are doing under fluoroscopy guidance, you can give dye. And it is recommended as well because there are a number of vessels close to it. So under fluoroscopy, it is recommended, but under ultrasound, there is no way. So under ultrasound, there is a new technique. You just found it in 2022 publication. They have shown that they are just undergone below the stylopharyngeus muscle. First, the located styloid process, then hold the probe in a long axis view, and under the stylopharyngeus, they injected 5 cc of the local anesthetic steroid. It's a newer technique. I have tried in 1-2 patients as well.
Yes, sir.
Okay, let us
Okay,
start the
let's go for the
procedure.
demonstration.
Yeah. Okay. So we will do the how to put the needle in a foramen oval. I mean needle in the foramen oval for RF of the Gasserian ganglion. So we will start first with the AP view. So this is an AP view. Okay. So you can see the picture, I think, clearly. So you know that which side is right side and which side is left side. So this is the patient will lie supine. Patient will lie supine, and this is right side, this is left side. And you can put the head on a ring so that it doesn't move. Or you can, I mean, the position, whichever you are seeing the picture, if patient moves when you are doing cleaning or draping, then the picture will move. So it is better to put the head on a ring, and otherwise any other pillow is not needed. So this is the position. So first thing we will see that which side is right side and which side is left side. So see, I'm just putting a forceps here. So I see that this side is right side. Okay. Now the procedure will start in the AP view. Now first you start while seeing the AP view, we can see that a question can come in our mind that whether we are seeing it in a true AP view or not. How to see true AP view? Just you see that both the orbits are looking similar or not. One big, one small. It should not be like that. If it is small, then it is true AP view. Then these are the petrous ridge. These are the petrous ridge. So these petrous ridges are in the lower part of the orbit, lower one third of the orbit. In the lower one third of the orbit, in both the sides, the petrous ridges are there. So it is more or less, this is the AP view. Okay, now where is the foramen oval? So foramen oval is actually in AP view. This is just behind the maxilla. These areas are foramen oval. Okay, so we cannot see this foramen oval here. Okay, this base of the skull is here in this area. So we cannot see. So from where we will see? So we will see between the maxilla and mandible. So this one is mandible. So our window is here. In this area we have to see, and our direction will be from lateral to medial. Window is here between the mandible and maxilla, and we will see from lateral to medial. Not only from lateral to medial, we will also see from caudal to cranial. These two direction you have to meet. So one is your submental direction. Your X-ray will go submental, and we will see from below. Okay, from below. And another is our X-ray will go oblique, and we will see from lateral to medial. With this two combination, with this two movement combination, we can see the base of the skull, and we will be able to see the foramen oval in this way. Okay, so foramen oval should be placed in the middle part. One part should be one side of the margin of the mandible, one side margin of the maxilla. So in this middle part, it should be placed in the middle. Okay, if you go too much oblique, then it will again go under the mandible, and if you are too less oblique, then it will remain under the maxilla. Okay, so let us see how we can see the how this foramen oval. So as I told you, so I am doing the procedure in the right side. Okay, so remember, while here in the right side, this X-ray machine, CM. So this is the receiver, and emitter is down. So this receiver is to come oblique. So we will go a bit oblique and then a bit caudal, step by step. Both the movements we will do a bit more oblique and then a bit more caudal. It is not that only oblique we will finalize it up to the last point and then we will go caudal. It is not like that. Okay, so let us first do 10 degree oblique. Yeah. Okay, so only 10 degree oblique. Now I will do 10 degree caudal. So remember, our main aim is to see this area. Okay, this area. When we can see the foramen oval. Okay. এটা মুভ করলে কি করে হবে? বাস দেখা। নড়েছে। আরেকটু। Okay, another 10 degree we have done. Now let's see again 10 degree caudal. So suddenly we can see one foramen oval. So this is the base of the skull, and we can see foramen oval. So we can see that still one side margin is by mandible and another side margin is by maxilla, but it is not in the middle, it is towards the maxilla still. So we can do a bit more oblique to bring it in the middle part. Okay, so now it is more or less in the middle part. Now let us see that whether we can make it more open. Remember this entry, this oval shape. This oval shape will be if it is an optimum position, caudal angulation, then only it will be maximally open. If your caudal angulation is less, then also it will be less open, and if it is more, then also it will be less open. So we'll make a bit less, a bit more angulated. Let's see if it opens more. Okay. So it is all right. I think nothing more is needed, but we can do a bit more angulation. Let's see when it becomes smaller. Still it is bigger. I have to go. Okay, so it is quite big now, quite big, and this one is in the middle position. So this is the perfect positioning. So we cannot do more angulation here, but we can do less angulation to show you that this angulation, if it decreased, then how it changes the shape. Okay, so here the angulation is much less, so you can see that this has become smaller. So sometimes this foramen oval is also, in normal patient, sometimes this oval, it is not clearly oval shaped, it can be a bit slit type like this, and whatever you do, it doesn't open. So anyway, we will change this craniocaudal angulation. We will make it a bit more or less to make it completely open, whatever possible. Okay, now so again we are going in the correct position. Okay, okay, so this is the perfect position. Now one more thing, that when we talked about that where to position our needle. So there was a earlier when C-arm was not being used, so people tried to put this needle through landmark technique also. So it is in the mid pupillary line and 2 centimeter away from the 2 centimeter away from the angle of the mouth. So this is a approximate your entry point for the needle. Okay, so mid pupillary line, and this should be 2 centimeter away from the angle of the mouth. And when you are entering, you are going to a plane which is just above the external auditory meatus. But let us when we are doing X-ray guided procedure, we do not need actually this one, this surface landmark part, but still I have multiple times seen that these two things are actually same. So this landmark based technique also, if you put the your forceps, the pointer there, it usually matches with the area where the C-arm is also showing the entry point. Okay, shoot. So you see, so I have kept it here, and it is like in the correct position. So I will go in the middle part of the, okay, shoot. So I will go in the middle part of the foramen. Okay. Okay, so this is the, just at the tip, I will put the needle. and this procedure is a completely tunnel view approach. This procedure is a tunnel view approach. So see here, angle of the needle, tip of the needle is angulated. It is not straight. So first I make it a more tunnel view. So it is going a bit below. So I will make it a bit up.
Sir, how do you know it's going below?
So there is a bony margin, this and this. So if you touch here, then also you will touch bone. If you touch here, then also you will touch bone. You have to be able to understand that which is tip and which is hub. So you see the plastic, this plastic part. This is telling me that this is the hub, and so this is the tip. So I am going in the lower margin. I am going to hit the lower margin. So let me just make it a bit. So again I have repositioned it. So again now I am going through the foramen. Okay. So after going up to say this much, so it can be completely a tunnel view also, but that is not needed. If you are in the foramen, then it's okay.
Can we see the needle on the mannequin, please?
What?
The needle. Can we see it on the photo? Just we see the needle on the mannequin, not on the X-ray, not on the fluoro.
But then you will not be able to see the CR movement. That's why.
No, just is. I mean, you said 2 cm from the angle of the mouth. The level of the needle is at the.
This mannequin is made by us and not by God.
In
That's
the
why
mid,
we.
in the mid pupillary line and 2 cm from the angle of the mouth. I am asking, the needle is at the level of the angle of the mouth, but 2 cm away.
And no, it is more away. But this is, as I'm telling you, that this is made by us. Okay, that's why every thing, eyes are not drawn in the correct position, or mouth is not drawn in the correct position. But in a normal person, normal human being, it is always in the mid pupillary line and around 2 centimeter lateral to the angle of the mouth. But of course, this is also I am telling, this is just for your first when you are putting the forceps under C-arm. Okay, nowadays people are not using this. This is a landmark technique. We are not using this. This is just when you are putting the forceps under C-arm just to see the foramen oval, then you have to put it somewhere, no, on the whole cheek. So for a guidance, I am telling you. But ultimately, it is the C-arm picture which is the final picture. You will go with the C-arm only. Okay, but most of the time, as I'm saying, that this matches.
Okay.
Here, of course, the picture, I mean, we have drawn it, so it may not be correct.
So if I draw a vertical line from the pupil straight down and then a horizontal line from the angle of the mouth, the intersection point I have to take.
Yes, this one. But this is not final. This is, I told you, this is just for first putting the forceps there, that whether it matches with the foramen oval or not. Sometimes how it is important, sometimes in some cases in normal patients also, foramen oval is not like a oval, it is a slit. Okay, then you get confused with multiple other shadows around. See here, this shadow is there, this side some shadow is there, so you can get confused in a normal person. If it is foramen oval is not like an oval, in that case it helps us. Okay, but if when you are seeing the oval very correctly, then actually your target is always the foramen oval and not the landmark technique, surface landmarks. Okay. So after going some amount of depth, now I will not go more. What I will do now, I will see a lateral view.
This is
Sir,
the
how
end on
do
view.
we decide how much like to go in AP and then to?
Yeah. So this is I mean, like there is no hard and fast that you have to go up to 2 centimeter and then stop. Nothing like that. When you feel that your needle is fixed there, because if it is under the cheek, under the just in the loose areolar tissue, then it will move like this. It will not in a right direction. So when you are at that depth, when it remains in the same direction, then you change your depth. Change your direction. I mean, from epi to lateral. Yes. Okay. So here in lateral view, there are some important things. I mean, like we have to see the true lateral view. So there are multiple things. Uh, just a minute.
So which is hub, which is tip here again?
What?
Which is hub, which is tip of the needle? Hub and tip of the needle.
So here it is a long. I mean, like it is a different, not the tunnel view. No, it is a normal. We are seeing from laterally the needle. So here this has to be the tip because it is deep here. Okay, it is going towards the brain. It is the tip, and this side it will be hub. This side we are not seeing the hub. We are still seeing the shaft only. So this is the tip. Yeah, we are going towards the brain inside. So okay, so here in lateral view, one important thing is we have to see a true lateral view. So how do we see a true lateral view? So mainly these are the angle of the mandible. Both side angle of the mandible should be overlapping. Otherwise, what happens that actual depth you may not be able to perceive. Depth sometimes it changes. I mean, like you may perceive in a wrong depth. Okay, then there are some other areas. That's it. Okay, so there are some other areas like these are the sella turcica clavus. So these are areas where you have to see one line. If you see two lines, then you know it is not a true lateral view. Sometimes external auditory meatus also, it should be one auditory meatus to make it one line. This is also a important structure, pterygopalatine fossa. This also can be one line. So these are the things you cannot overlap all the things together. So it is not possible sometimes to make all the things together to make a to see a true lateral view. So at present we are interested in the cleopatral junction. So what is that? So this is the petrous bone. This is the petrous bone, and this is the clavus. This is the clavus. So direction is this one. This is our direction of needle. So this area must be overlapping. So we will see that this is one line and this clavus is also one line. And as far as possible, this angle of mouth also, we will see that whether it is one line or not. Okay. So let me make it a bit more here. Should. So this angle of mouth has come as one line. So this is more or less the true lateral view. Now what we can see that this direction is, if it goes like this, then it will go towards this. Means this is the petrous bone and this is the clavus. So our direction is correct. Okay. So let us go inside. So here the tip is very difficult to see that how much the tip has gone. So remember this tip here we can see a bit, but you may not be able to see sometimes in a normal patient. So remember, as we can see the petrous and this one, so you target this point and it should be just seen here, not more than that. Okay, just seen here. Okay, so this is the correct position. You don't have to go more. Okay, so this is the lateral view. Any question here? This is the lateral view. Okay, now let's see the epi view. So this is the AP view, but here you cannot, this is the AP view. This is, as I told you last time, while starting, that from where is the foramen oval in AP view, the foramen oval is in this area and it will come out gradually. When we will, in this direction, it will come out when we will see submentally and from obliquely. So the earlier position. Let us see in the earlier position.
Sir, how much oblique and how much lateral rotation roughly?
So that one I told you that you cannot fix it for any patient. This is you go on changing for certain patient. 10 degree, 10 degree, 10 degree oblique, 10 degree caudal, then again 10 degree oblique, 10 degree caudal. So like that, you cannot.
Oh, okay, sir.
Yeah. So it cannot be fixed. Okay. It একটু বেশি হয়েছে একটু কম কর oblique. Yes. So we can see that this is in the right position. And now one more thing, you can see that small tip, the tip is a bit angulated. Okay. So from outside also, I can change the angulation. Now shoot again. So you see the tip, I can make it completely rotated. Okay. So in different angle, I can change it from outside. Okay. So in this way, when we rotate the hub, the angle of the tip also changes. So we can make the lesion size a bit bigger. So in submental view, this is the view where how you enter. So this will look like this. And in lateral view, already I showed you that we will just cross the cleopatral junction. And AP view is not needed in that way. So this is the way how we do the Gasserian ganglion RF. So after putting the needle there, we will go for sensory stimulation and motor stimulation. So sensory stimulation or motor stimulation also, patient will say that in sensory stimulation, patient will say that whether the area is stimulated, where the pain is there. Either we can target the V2 division or V3 division. So if my needle reaches here in this side, then I am targeting the V3. If I am in the middle, like as I am place the needle in this case here, so I am at present stimulating the V2. Okay. So if it matches the area, which is the patient's painful area, then we will go with the lesioning. We'll go forward to the lesioning.
Sir,
okay.
Sir, since before RF we have given some amount of local anesthetic, will it affect the sensory perception?
Because yes. If you see, if you give local anesthetic once, then you do not think that again you can stimulate. Okay. So like before radio frequency listening, when you give the first local anesthetic, say 0.1 ml, 0.1 ml of lignocaine as you have given. After that stimulation, after that, sensory or motor stimulation doesn't have any value. Patient may not find any paresthesia or anything if you have given local anesthesia there. But of course, as I'm telling you that when we have put the needle in the correct place after stimulation is done, I have seen that needle is in the correct place, then as patient cannot tolerate the RF, then I will give some local anesthetic and then I will do the stimulation. Then I will only change the direction to make the lesion bigger. Okay. But at that point, you, if you come out again put a needle there, there is less chance, very less chance that you will be able to stimulate again, sensory stimulation, because local anesthetic will spread. Okay.
Sir, how will you do the motor stimulation?
So motor stimulation also in the same position. In the same position, when you are giving motor, I mean, like in radio frequency, there are two modes, no? Sensory stimulation, motor stimulation. Sensory stimulation, it is the 50 hertz, and motor stimulation, it is the 2 hertz stimulation. So as soon as if it is on the mandibular branch, so immediately mandible starts moving. Okay. So actually our mandibular branch only, that is the V3 is the only motor, has the motor supply. So immediately this will move, nothing else.
With the spinal needle, we can't do, right? So,
No, then electricity will go everywhere, no? Because it is conducting everywhere. In RF needle, what happens? The active tip that is open, electricity is coming out from there in the active tip, not in the other part that is insulated. Okay.
Sir, in tunnel view, we don't know which is hub, which is this needle tip. So then won't it be difficult to
No, this is a, I mean, few days thing. I mean, you will be able to understand. So here in tunnel view also, the now here in tunnel view, of course. So if I just change it a bit, একটু oblique করে দেব। Mhm. So now it is not in tunnel view. But this picture is not good. So, আচ্ছা, সোজা কর। No, this is the plastic hub, nothing else. This is the plastic hub. So you have to see the plastic hub. So actually this one, this is the tip and this part is hub. This part is hub. Okay. So yeah, I mean, this is usually seen. This is usually seen. Sometimes the tip, the angulated tip is also perceived. This can be perceived. This is not a very big issue. I mean, you can understand all the spinal type of needle, not spinal needle, RF needle also. You can understand by the seeing the hub, that which one is hub. And sometimes, say in some patient, you are not getting the which is tip and which is hub, then I will hold the hub like this and I will take an X-ray. So you can see which is hub like this.
Yes, sir.
Okay.
so in
this
this
one
case,
is,
you are targeting V2, right?
yeah.
What if we have to target the V3 division? We have to take the needle out again and redirect or manipulate from there itself.
From just a bit of manipulation, nothing, you don't have to take out. You don't have to take out. Just you come out a bit and put here. That's it. We can put it just agar position again. I just put it again. Yeah, ekdam here position. Okay. So at present it is in the V2 division. একটু কম কর। একটু কম। So I have decreased the obliquity because it was going towards the mandible. Okay. So now it is in the V2 division. So I'm coming out a bit and then I'll just make it a bit lateral. In Maniquin, actually, it becomes a bit problematic because of it takes a preformed path. It is going again and again. So so I can touch there in the bone also. So there is something is there. So it always takes the preformed path. Okay. Okay. So now I'm going towards the mandible, mandibular branch. Okay. So here I can just go over it. Okay. So this is the mandibular branch, positioning of the needle in the mandibular branch. Now lateral view, just show. So here also it should go towards the uh, cleopatral junction. Yeah. So it is going in the right direction. So I'm just going a bit more. I cannot see the tip. Now I can see the tip. Okay. So it is just crossed the cleopatral a bit more. Okay. So it has just crossed the cleopatral junction. This is the junction. Okay. So this part come like this. Okay. So this is the cleopatral junction. So this one. So this is position for V3. Okay.
If we go lateral to it, it is V3, and if we go medial, it is V2, sir.
Yes. By C-arm, it is like that, but of course you have to stimulate also. So I mean, like usually it is always matches. I mean, if you remain a bit lateral, then you are on the you are stimulating the mandibular nerve more. There is the more chance. Yeah.
Sir, here if we give dye also, we can't see, no, this area.
No. Dye is not needed here. Much less drug. No drug is needed.
So can we see the foramen rotundum for the V2, or we just do the foramen?
No. Everything is through the foramen oval only. There is no such procedure which you can do through foramen rotundum. Okay.
Actually, if you want to enter through foramen rotundum, you need almost a more than 90-degree rotation, because you can go towards the maxillary division and then you have to turn almost over 90-degree, 100-degree to turn back. So a needle cannot go with a 100-degree turn.
Sir, for diagnostic block, only local we will give, no? And then for therapeutic, local plus steroid.
Yes, therapeutic steroid is not much effective. Actually, for the therapeutic, we have to go mostly for the radiofrequency ablation.
Actually, this is a very dangerous.
Or you can
Yeah.
go for a neurolytic injection like glycerol. I have done long back. I was in a government hospital that time. Radiofrequency was not available, so I have done few cases. But the problem is you have to do it repeatedly. Almost every 3 to 4 months, the patient comes back.
This is
And
a I
especially when
mean,
you are injecting neurolytic, now for radio frequency, you can avoid injecting the dye. But if you are injecting neurolytic, in that case, it is very important to inject the dye as well.
And this is I mean, very tough procedure, or say very, I mean, you can have multiple complications. So multiple times we cannot do. We cannot do once diagnostic followed by another this one your definitive procedure. So better plan for the RF only, and then you can do the radio frequency, because diagnosis is almost correct all the time.
Balloon decompression is like the same procedure, sir. We used to
Nearly same procedure, but under GA, and patient needs admission.
okay.
And here in balloon decompression, what is usually done, the procedure is a little bit painful. So, and the thickness is much higher. So you have to first put the balloon and inflate it there. But the rest of the technique is the same.
Sir, I just wanted to understand the path of the needle.
Mhm.
When the patient should be sedated, or if patient opens the mouth, then the needle will move, no, sir, because needle has to pass
See,
skin, subcutaneous
You
teeth.
just check an Asian Pen search in the Asian Pen Academy YouTube, and there is a video which I have put. So I can there is a patient video is also there. So what we do usually, we sometimes, it is not always, that if the patient's cheek is very thin, okay, if the cheek is like me, you can do anything, no issues. So I use a double gloves in my left hand, and while putting the needle, I put one finger in the mouth of the patient. Okay, and after the needle has crossed the oral area, then I take the gloves out to
Sir,
keep
we
the.
have to pierce the hard palate, no, sir?
No, no, you don't have to pierce the heart palate. You just try to understand. Okay, just I am again focusing on myself. You can see the path actually. Okay, when can you see the foramen oval now? Try to see
Yes, sir.
in between the maxilla and mandible. So are you piercing the heart palate?
What you are seeing, your X-ray machine is also seeing in the same way.
In the same direction.
So this will be like retromolar approach. I mean, you can lift the lip and again go intraorally also, sir.
No, no, you cannot go intraorally because in that case you will be medial to the alveolus process. Our target is lateral to the alveolus process of the maxilla and medial to this coronoid process. Okay, so in between these two, maxilla and mandible. Okay, you can see the foramen oval na, in from this angle.
Yes, sir.
So this is our path, needle path.
Okay, sir.
Sir, in previous class we said trigger point injections. Whether particulate or soluble steroid we are using, sir, for all
In
this?
trigger point is a very simple injection. In trigger point injection, we usually prefer giving the particulate steroid rather than the soluble steroid. But also there is a concept is that in trigger point you might avoid giving anything because even if you do the dry needling, or sometimes it is said that if you give only local anesthetic, that also works. But we usually give a little bit of particulate steroid there.
Sir, and in first class we said pain and nociception is different. So if the patient is undergoing surgery, there is both pain and nociception, no, sir? Acute pain.
See, in acute setup, they are literally the same, but in chronic pain, it is not the same.
Yes.
Okay, let's go for the quiz.com. Requesting all to join, please. What happened? Just 1 second. Okay, let me. The website was a little bit slow.
Bouncy Bouncy Boy, Clever Goat, House Dog, Doctor, Uncle Fork, Bharith Narayanan, Abita Fiber, S. Bisak, Anusha, Dr. Boat, Bouncy Fire, Brother Snail, Toilet Cow, DOCC, Quiz.com, Play and Create.
Which branches of the trigeminal nerve
Freak
is most
Steam
commonly
joined.
involved in trigeminal neuralgia?
Nanometer joined. Fluffy heat joined.
V2 and V3. What is the first-line pharmacological treatment for trigeminal neuralgia?
Cool space joined.
Carbamazepine. Which of the following is a known trigger for trigeminal neuralgia pain? Light facial touch. What is the most common age group affected by trigeminal neuralgia? (50 to 70 years). Which imaging modality is primarily used to rule out secondary causes of trigeminal neuralgia? MRI. Which invasive technique involves moving arteries away from the trigeminal nerve? Microvascular decompression. Which of the following procedures uses high-dose irradiation for trigeminal neuralgia? Gamma knife radiosurgery. In the somatotopic arrangement of the Gasserian ganglion, which nerve lies most medially? Ophthalmic. What is the most common complication following RF lesioning of the Gasserian ganglion? Sensory loss. Which procedure is best suited for elderly patients with trigeminal neuralgia? RF treatment.
Final question. Double points.
What is the ideal sensory stimulation frequency during RF procedure testing? Hz.
Third place. Brother Snail. Second place. Doctor. And the winner is Bharath Narayanan.
Hello.
Hello.
So, yeah. So Dr. Bharat Narayanan was first. This time.
Okay, so let's finish today. So please check the study material as well as the MCQs that will be given in this week. Okay, so let's end the class today.
Yeah. Let's end. Thank you.